On behalf of the Canadian College of Health Leaders, it's wonderful to join with you today. Before we get going, it's very important to us that we start with our Indigenous land acknowledgement. So we pay respect to the Algonquin people, who are the traditional guardians of the land on which I am broadcasting with you today. We acknowledge their long-standing relationship with this territory, which remains unceded. We pay respect to all Indigenous people in this region from all nations across Canada who call this place home. We acknowledge them as traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future. We also want to make sure to recognize all frontline workers, particularly in health. When I broadcast from home, there's a rainbow above my right shoulder, the international symbol of that appreciation, painted by my niece, who's 4. We thank you for all that you do. If you're on the front lines or you support those who are, we are keeping you in mind and appreciative for all you do. So today, I'm very excited to introduce this session. I'm a leadership academic, but my father has spent his entire career on anticoagulants. So I've actually been to more blood clot conferences than I've been to leadership conferences in my life. So warfarin and Coumadin and others are familiar terms to me as a kid growing up. And so this session, Community Pharmacist-Led Anticoagulation Management Service, I'm sure you're going to find this very exciting. And so this webinar is to provide the context for the article that appeared in the November edition of the Healthcare Management Forum, the college's journal. The November edition is all about access, and this article addresses how pharmacists can help patients to better manage their medication and improve access using their expertise through a new model of care. Even more important now as we're in the second wave, that how we can find innovative and effective ways to work together, in particular to take some of the burden off hospitals with other people, other health professionals. So without going further, we have a more formal introduction from my colleague at Roche, Francois Drolet.
Thank you, Jason, and good afternoon, everyone. Back in May, I had the opportunity to host one of these webinars, and let me tell you how pleased I am to be back for today's event. First, let me commend the college for the fantastic work during the past 50 years. I'm truly convinced that beyond technology and science, leadership is likely the #1 weapon we have at our disposal to fight the pandemic. And we've seen the impact of great leadership in countries, jurisdictions, or institutions that have done better than others, like in Canada. And sadly, we've also seen the opposite. From one Premier Trudeau to the other, yes, in 1970, when the college was founded, it was Premier Trudeau, just like today. And as demonstrated once again since the beginning of this pandemic, the college has been constantly reaffirming its relevance. So kudos for the past 50 years, and we look forward to the next 50. Now let's talk about what brings us all together today. The presentation theme, a novel approach to managing anticoagulation, will feature the Pharmacy Association of Nova Scotia and an innovative care model that they have piloted over the last couple of years. When reflecting on this presentation, I was thinking that when we talk about innovation, our brain often, if not always, defaults to thinking about highly sophisticated and complex technologies, artificial intelligence, surgical robots, and the like. While sometimes it's quite simple and just there before us. Today, you will hear a story that involves the use of a 20-year-old INR monitoring device and a drug, warfarin, otherwise known as Coumadin, introduced in 1954 and genericized in 1997. All it took was the leadership, creativity, and dedication of pharmacists, a group of healthcare professionals that make such a contribution to the healthcare system. We have actually seen throughout the pandemic how much they can take in the efforts of healthcare systems to deliver care closer to home, and we certainly hope that they can be leveraged even more in years to come. In this project, rather than starting with the technology first and building around it, they truly started with the patient in mind to re-engineer the care pathway, taking these latent innovations, as I call them, layering IT connectivity and a digital tool to help patients achieve better outcomes, better patient experience while being cost effective. For any innovation, you will agree that this is the ultimate the Holy Grail, or a perfect storm. So let's get down to business and allow me to introduce our guest speakers, starting with Lisa Woodhill. Lisa is currently the Director of Pharmacy Practice for the Pharmacy Association of Nova Scotia. In this role, Lisa is responsible for pharmacy professional education and conference programming and pharmacy practice support. In addition, Lisa is the project lead for various demonstration projects, including the Community Pharmacist-led Anticoagulation Management Service, Prescription to Thrive, and Let's Quit, in which Nova Scotia pharmacists optimize their scope of practice to provide valuable services to their patients. Lisa received her BSc from Dalhousie University in 1999 and has worked in various positions, including Director of Professional Development, Regional Pharmacy Manager, and Manager of Pharmacy Ontario and Western Canada for Sobeys National Pharmacy Group. Next is Alison Bodnar. Alison is the CEO of the Pharmacy Association of Nova Scotia and the happy mom of 5 children. The association represents almost 1,300 pharmacists, technicians, and students, and over 300 pharmacies throughout Nova Scotia on all matters related to the profession and practice of pharmacy. After practicing law with the law firm of Patterson, Palmer, Hunt, Murphy for almost 7 years, where she specialized in tax and financing transactions, and prior to joining the association in 2009, Alison worked as a corporate lawyer with Bell Alliant Telecommunications and as a VP of General Counsel for the Credit Union Central of Nova Scotia for many years. She received her law degree from the University of Toronto and her BA from the University of Western Ontario. With that, over to you, Alison.
Well, thank you, Francois, and thank you, everyone, for joining us today. Just as an introduction as to why you're seeing us here today, and I think I'll sort of build on what you said, Francois, and it's as an advocacy body for a profession that today actually has, unbeknownst to most people, quite a large scope of practice. I think many people would be surprised to know that pharmacists in Nova Scotia can prescribe for contraception. Pharmacists can provide all sorts of injections. We can do point of care tests like the anticoagulation. We can prescribe for minor ailments. We can do chronic disease management. And that's all great in terms of a scope of practice, except we live in a country of a publicly funded healthcare system. And unless those services are funded by government, they're very difficult to sort of make your way into that system. So our role, my role in particular, is to find projects like the one we're going to talk to you about today, to demonstrate the value that pharmacists can bring to our healthcare system. And Francois, you talked about innovation, and it's interesting because the innovation is really rethinking how we use our healthcare providers. Because you're right, the technology here is not new. The drugs are not new. In other areas, whether it be chronic disease management, these things aren't new. But what's new about what we're talking about is how the system utilizes its healthcare resources, how we interact with patients, how we previously expected patients to fit into our model, come when we tell you, to the place we tell you. What this project demonstrates, and many of the others we demonstrate, is that if we meet patients where they're at, if we meet patients in make it convenient for them, if we help them better understand, if we can just take a little time on their terms, that we can make significant clinical outcomes. And that's what you'll see with this project. For me, when I started reviewing this project or thinking about projects, I think this was back in 2017 now, I was really looking for that intersection of success. Success that would be great for patients, a service that pharmacy could provide that patients would utilize and want to utilize, and more importantly, be comfortable utilizing. something that would be good for pharmacists using our scope or using their scope to their full potential, and good for the healthcare system in bringing down costs overall. So I spend a lot of my time looking at what is it we could do differently in healthcare. And so that's really what brought us to this project. So I was researching areas that I thought might work, and I came across, quite frankly, this project in New Zealand. So we're not the innovators of this project internationally. Give credit to the research team in New Zealand that designed this community pharmacist anticoagulation project and implemented it very successfully. So we were able to hit the ground running and we made a proposal to our government here in Nova Scotia and worked with our Doctors Association as well. So in 2018, we kicked off this project, jointly funded by the Department of Health and Wellness and carried out through Doctors Nova Scotia, as well as the Pharmacy Association. So really one of the things that we were dealing with here is warfarin is inconvenient for patients. I don't know how else to say that. You know, you have to be tested regularly because you have to go to a lab and travel. We knew there was high incidence of non-adherence to the testing schedule, which means delays in adjustments to treatments, delays in communication of results, and we knew that the care, the outcomes weren't great, and so we needed, and policymakers, those in government who were looking at warfarin, were starting to question the efficacy of warfarin in light of the fact that we had a new class of drugs, the novel anticoagulants, that don't appear to need the same level of testing and monitoring. And so we knew this was out there, and we knew we needed to find something that would address that. So Lisa, can you change the slide? So we wanted to ask these questions. So does warfarin still have a place in therapy? And if you have your question and answer and you have thoughts on this, you want to get used to using the question and answer box, feel free to put your thoughts down there, and that will be where you'll ask questions later as well. But does warfarin, in light of NOACS, does warfarin still have a place in therapy? If it does, could warfarin treatment be improved? And then again, what about the NOACS? They were very expensive. They're not so expensive now, or they're becoming less expensive. Where do they fit in with this? So we worked to design this project, and in late 2017, we received 73 applications from pharmacies who wanted to participate. So we had a limited budget. We selected 40 pharmacies. We made it a requirement that from each of the pharmacies involved, that at least 2 of their pharmacists would complete the University of Waterloo MOAT course. So there was 106 pharmacists in total who took this course, quite an extensive, it's about a 30-hour, I believe, in total, 30-hour course on the management of anticoagulation therapies. Each pharmacy then received a CoaguCheck XS Pro, and they received a subscription to an online decision support software tool called INR Online. Most patients who were on warfarin, generally speaking, older patients, most were already on our public pharmacare program. And so there was a fairly sizable, significant eligible patient base for us to draw from. Pharmacies, we spent a lot of time, trying to think of innovative ways to fund this project as well. Was it going to be a per test? how were we going to do that? So we also looked at a flat fee. So pharmacies receive a flat $50 monthly management fee to manage the patients optimally. So that may mean they had one test every 4 weeks. That could have meant they were tested weekly or even more so if they were unstable, and pharmacy would still only receive that $50. So we needed to really look at whether this type of per capita model was effective as well. So the initial pilot enrollment was from February 2018 to July 31st. So 6 months of enrollment and then 12 months of care. So you can do that math, and the pilot concluded officially in 2019, and the evaluation continued. But as an interesting side note to this, when we talk about the innovation here really being around improving access, it was recognized in the middle of the pilot that unattached patients in the province, so patients who didn't have a family physician, were at risk of not having their warfarin properly managed, or worse, not being able to access that therapy. So in addition to our pilot project, government has authorized, and it continues to this day, a program for unattached patients. So we have now, I think, about 150 patients who do not have access to healthcare in any other way, having their INR, their anticoagulation, managed by pharmacists. So we then had to, once the project concluded, it has been evaluated. So there's actually 3 evaluations we're going to talk to you about today. The first, and what drives the rest, was the clinical evaluation. And this was conducted by an independent research firm, Research Power Inc. They're epidemiologists there with expertise in project evaluation. They do a lot of work with the Department of Health and Wellness here in the province, as well as work with a number of the drug manufacturers around the world. So they did the first evaluation, and then that clinical evaluation then transposed into a costing analysis. And Lisa's really going to talk in detail about that. So there was 2 costing analyses done. The first and the main one that was, I would say, it was identified along with the clinical evaluation up front, and that was comparing the cost of this new approach to managing care compared to usual care. So care managed through a traditional physician's or nurse practitioner's office. One of the things that happened during the course of this project, and I alluded to earlier, is the NOACS, or the novel anticoagulants, have gone generic and are going generic as we speak. And so that brings down the cost of these products significantly. So what we needed to, in addition to looking at, does CPAMS make sense compared to usual care, we really had to look at how does CPAMS compare to the use of NOACS in the population that can easily go to a NOAC. And so we retained the same economists who had done the costing analysis to compare CPAMS outcomes and costs to NOACS. So Lisa will talk about all of those as we move forward. So Lisa, I'll turn it to you.
Thank you. I doesn't want to go. There we go. So this is just a slide that gives some of the areas where the pharmacies were located during the project. So in Nova Scotia, we have 4 different health zones: central, eastern, western, and northern. So they were fairly well distributed amongst the health zones. We also wanted to ensure, and when we were selecting our pharmacies, we were trying to ensure that we had a good mix of pharmacies that were in each zone. Also, we wanted to look at small cities, rural versus urban sort of settings, to make sure that the model applied in all of these different type communities. So you can see on the slide as well, just a mix of small town being the most common, 48%, also representative of the Nova Scotia geography as well, and then 23% in the city, and so on. And then these are some of the indicators and their outcomes that we focused on in the project. So total number of patients were 946 patients that were enrolled as of the end of that enrollment period, which was July 31st, 2018. By the end of the project, we had 746 patients left in the project. And so there was a number of reasons that patients left the project, and you can find the full list outlined in our report on our website. But the most common reason was that they were, as Allison was talking about, that they were switched to either a NOAC or a DOAC, or in some cases their warfarin treatment ended because of the indication that they were taking warfarin for it was no longer required. Another common reason, not quite as frequent, but also that we saw, was that they moved communities. So we only had this in 40 pharmacy locations around the province. So in some cases, they moved to a community where it wasn't possible. And then in some cases, they moved to long-term care facilities, which during this project, it was only available in the community pharmacy, not in a long-term care setting. So on average, pharmacies had 18 patients per pharmacy. There was a large range. There was one pharmacy that by the end did not have any patients, and then one pharmacy that by the end had as many as 61 patients still enrolled. So a good range, and it depended certainly on the number of patients that they see on a daily basis and those that were taking warfarin within their pharmacy. All in all, 21,597 tests, INR tests, were completed over the course of that 18-month period. And the total number of tests per patient per month averaged at about 1.7. So this was really important because, as Allison mentioned, we also wanted to know if this is feasible and sustainable in a community pharmacy from an economic perspective. So knowing how many tests per month, the pharmacies were responsible for purchasing their own test strips and their own supplies to provide that test. So this was a significant number for us to know, as well as the length of time per patient for the test, which was about 10.8 minutes. And that includes both the testing time and the follow-up time. We were really pleased with the number of primary care providers and nurse practitioners that referred patients into the project. That was one of our biggest discussions that we had with the Doctors of Nova Scotia, the Association for Physicians in the province. Initially was, because this was a model that we hadn't really tried before, this sort of referral model. And at the time, now our standards of practice for prescribing for pharmacists have changed slightly since we started the project. But at the time that we started the project, the pharmacists were prescribing under a collaborative agreement with a physician or nurse practitioner. So the nurse or physician had to provide the diagnosis, send in a referral form, and it outlined who was responsible for which pieces of the care. And we weren't really sure, how many physicians and nurse practitioners were going to feel comfortable with that. But it turned out to work out really well. So the pharmacy teams that were participating visited with their local family physicians. They set up a meeting time with the physicians and if there were nurses at the practice to go over the project and talk about referrals. They met with a total of 275 providers, and 225 physicians and 12 nurses out of that group ended up referring to the project, referring patients to the project. So we were really pleased with that. Which was fantastic. We knew it was a challenge because the number of warfarin patients per pharmacy, there were so many different physicians and other prescribers that were sending warfarin prescriptions into the pharmacy that we knew we had a really broad range and a large number of people to work with. So that was great. So percentage of tests outside of the 1.5 to 4.0 range. So this is significant because within the project, the pharmacists were prescribing independently within that range. But when the test fell outside of the 1.5 or the 4.0 range, they did consult with the referring physician or nurse practitioner to determine the best course of action. So that happened about 7% of the time. So one of the initial concerns by some of the primary care providers was how much time that was going to take, like how much time they would be back and forth with the pharmacist, but it turned out to be minimal. And we'll talk about their opinions in a bit, but they were pleased with that 7% range. So today, pharmacists are the patients that were originally enrolled in the project are continuing to receive the service, as well as I also mentioned the patients that do not have a primary care provider. So for these patients, and since the project finished, they are prescribing within any range, and what they're doing is if they have a result that they're concerned about, so for example, they feel that they might need vitamin K or they may need to be referred for assessment for bleeding, or emergency care, then that's when they would contact the primary care provider, or in a lot of cases, send them to the emergency department. And then time and therapeutic range. So this was our key clinical indicator to see what percentage of the time were patients in the range that, for the most part, 2.0 to 3.0 range that they needed to be in. So you can see we have a couple of different categories on the screen. We use the Rosendahl method as well to calculate TTR. There's a few different methods that you can use. So when we looked at all patients from the beginning of the project or throughout the duration of the project, all 946, they had an average time in therapeutic range of 71.4. 67% of those were greater than 65 and 40% were greater than 75. So then when we looked, we also took a snapshot of the last 5 months, which was 785 patients. And during that time, the final 5 months of the project, it was 75.7. So I will just note here too that since that time, we've also done an analysis of those that are continuing in the project 6 months out after we ended the original data analysis, and it remains at 75%. So the reason we looked at that 5 months, couple of reasons. Number one, during the project, there was an urgent medical device correction with the strips that we were using for the CoagCheck, in that any of the results that were 4.5 or higher were not reliable and not accurate. And so in many cases, we were able to confirm that as well, because we sent the patients with those results to hospital labs to have a confirmatory test result. And in fact, they may have actually been within the normal range. So we know there was a problem within that time frame. Now by February of 2019, that was corrected. So from February to the end of July 2019, we had confidence in the test results, and that was one reason we looked at that period. The other reason was that the historical data, so we didn't really have a way to compare these specific patients to their historical data. We didn't have access to their lab results in the past, but what we did have was 3 historical test results. So when physicians or nurses were referring patients, we asked them to let us know what their past 3 test results were so that we could ensure we were putting them on the right dose to start. So we did compare those test results, which averaged over a 4-month period, so also close to that 5-month period, and they had a result of 71.6%. Now, that's quite high for historical test data, because when we look at usual care, so the data in the literature usually has a TTR of 50 to 60% for North American warfarin patients. Also, interestingly, we looked at those patients that left the project. So we had data for 184 of them, and their time in therapeutic range was 62.1%. So as we had mentioned earlier, some of those patients, they left because it was decided that they were not able to attain a TTR that we wanted, and they were switched to a NOAC or no longer on warfarin in those cases. So this study, we didn't design the study to compare frequency of adverse events or compare it to other studies, but we did want to ensure that we were tracking that and reporting on it. So I think this is a table taken directly from the evaluation report, but the most significant items here would be bleeding, 13 tests. So I should explain that a bit. So when a pharmacist did the assessment with the patient, there was a number of questions that they would ask them before they did their INR test result, so that they could assess whether or not, how reliable or what recommendations they want to make based on the result. One of the questions was whether or not they had been hospitalized since their last test, and also whether or not they'd had any symptoms of bleeding specifically. So that's how we have this data. So it's reported by the number of tests where the pharmacist documented at that time that there was an event. So there were 13 documented hospitalizations that were caused by bleeding and 3 that were caused by clotting out of all the test results. So fairly small number out of the overall number of tests when you look at that, over 21,000. So bleeding being 0.06% and clotting 0.01%. And of the bleeding events, only 6 of them were considered major bleeds. So major bleeds, that was classified by bleeds that ended up in hospital, but also those that were intracranial bleeds, bleeding from the GI tract, bleeding from the urinary tract, or a bleed that required blood transfusion was also in that category. And then over here on the side too, you'll see figure 14. When we looked at the safety and efficacy, we wanted to also compare that to what we could. So we compared it to the historical results as well as CPAMS New Zealand. So INR results less than 1, comparable to New Zealand 3.3 to 3.9, and a little bit less than the historical results. And then those that may be at higher risk of bleed, greater than 5 and then greater than 8. Greater than 8, all very comparable, 0.1%. So next we're going to play a video, because I think the best way to really give you a feel for how the project went was to hear directly from some of the pharmacists, physicians, and patients that participated in the project. So I'll play that now and you can hear directly from them.
As a pharmacist, you want to provide more services to your patients. So by bringing in all those demonstration projects and trying to increase the awareness in the community of all the things that pharmacists can do, not just dispense medications, we're creating that culture of people coming into the pharmacy, not just for getting their prescription, but for getting health advice and for getting other things as well.
Reading INR and kind of making the right decisions on adjusting certain medications is a skill, but it's certainly a skill I think that's within the skill set of pharmacists.
I'm really happy we did it. It's great. And patients love coming in here. They said it's so much more convenient for them rather than having to go to the lab, have their blood drawn, and then it gets sent to the doctor. The doctor calls them. We do everything right in the pharmacy here, so it's great.
I do love it. Yeah, the people, it's a great chance to interact with the patients. Coming here, it just takes a lot of stress off, and by just pricking your finger, it's so much easier and less stress and less pain. I know everything before I leave the office. When I have to come back, what dosage I have to take, or if I stay the same. So it's very convenient.
They send the INR thing right to the doctor, and if they see anything that they think needs to be fixed or taken pills away or added on, they contact the doctor and then they make a decision.
It's about convenience for our patients. I think in healthcare in many ways we're understanding that we have to adapt and be adaptable. So the INR program is certainly a great example where INR testing, going into the lab, waiting at the lab, is the lab even in the hospital today? Those are issues that we have certainly in a lot of rural hospitals.
Medicine's becoming more and more complicated and more chronic illnesses to try to manage, and I think we need to accept the help that the other allied health professionals can provide to help us manage these complicated patients, and also patient convenience and patient buy-in and patient compliance is very important. So we have to make it as easy as possible for them to access some of the other parts of their care. So if a pharmacy can provide that, then I think that's wonderful.
The INR project has been fabulous. Not even for my own patients, but working in the emergency department once upon a time, if I was starting somebody on warfarin on a Thursday, that on Saturday or Sunday they're going to need an INR checked. And so my previous advice has always been, okay, you're going to have to go to the emergency department, register. Your triage level is going to be very low because you're waiting for blood work results. And you're going to have to sit there and wait until you get seen and your INR is done and somebody can give you advice about that. And the difference now, saying, great, I'm going to fill out this little bit of paperwork and send it off, pop in on Saturday, get your INR done, and they'll adjust it for you. That changes the world of warfarin management, really.
Face-to-face discussion with the patient about the dosing and looking at the pills and all that can save mistakes. Because oftentimes what we're doing is telephone conversations with elderly patients, telling them how to adjust their drugs, so we're not there with them. So I think mistakes can happen. I think with this new system, the patient can come in, quickly have their blood drawn, and be told right there and then what the adjustment may be. And the pharmacist knows exactly what the milligrams are on their pills and is having a face-to-face discussion with them, which I think is important.
So it's timely advice.
tremendous opportunity for us to show patients the true value of pharmacy. The lead pharmacist doing the INR management, it would probably take them less time to do this test than to check a prescription.
There are many times where I will cheat. You know, on the game show you can phone a friend. Well, sometimes I phone a pharmacist. And that actually allows me to speed up my day sometimes in a variety of different ways.
Then it really makes a difference in the patient's life, and it really makes a difference in our lives to be able to feel that sense of accomplishment and know that we're actually improving their health.
So essentially it was some physicians and some pharmacists and patients that were just talking about some of the benefits that they had within the project. So what we'll go through the verbal results that we've received from the surveys with patients, pharmacists, and the interviews and focus groups with pharmacists and physicians. And I'm just going to hand it over to Allison now.
Thanks, Lisa. So yeah, I mean, I think this project was really great for us as an association, and in bringing new services to the forefront was the response from patients in particular. So Lisa, I think you need to share your screen again. You want to put the presentation back on, but I can start while you get that going. So the patients, like I'll give you an example. And I'm going to go through the stats, and the stats are what they are. But I remember one pharmacy manager calling me in particular as the project was winding down, and he called me because he had become a district manager, and he was in the pharmacy, which was in this particular instance was a sort of a grocery store format. And a patient that had been his when he was working in pharmacy yelled from one side of the pharmacy across the other, across everybody who was there could hear, basically to say, "Don't you blank dare take this service away. This is the best thing I've ever had." And that maybe not quite as verbal, but that kind of response repeated itself over and over in this project. We had really tapped into something that patients liked and needed. So in terms of patient success, 98% of the patients in this project said they preferred to have their warfarin managed with this model. We knew it was going to result in improved access and convenience. So we, saved 76 minutes from waiting and the care time, and 4 minutes of travel time, which maybe was a little less than we had thought. But overall, people were reporting significant increase or savings in the time they had to spend to manage this issue. One of the other surprises of this project, and me not being a healthcare provider, was the response to the finger prick point of care test over the venous blood draw. So as we mentioned earlier, most of these patients are elderly, and getting blood becomes more of a challenge as we age. And so almost all of the patients commented on how nice it was only to have to do a finger prick blood draw over having to go to the lab and have their blood drawn. We also saw significant increased adherence to testing. So as we mentioned at the outset, one of the drawbacks to warfarin is that it requires frequent testing, and humans are humans, and we're not great at keeping schedules. So what we found with this project, and one of the was 80% or more of the tests were done on or before their due date. And part of the reason for this is, again, I think it's convenience, but in the way these tools that we utilize work, the CoaguCheck XS Pro as well as INR Online, is we could provide patients with the schedule of their testing, provide them with reminders, and provide them with sort of an open window of when it was convenient for them to come in. So we weren't forcing them into a lab on a particular day that may or may not have made sense to them. We saw increased adherence to their medications. So people were taking the doses that they should be taking. And we saw a significant improved understanding of their condition. So with that time, while they were waiting for test results and things like that, pharmacists were able to talk with patients about their condition, about their lifestyle choices and how that impacted warfarin management. And so this was, patients liked this. They liked the feeling of having more control over their healthcare. And as Lisa has already mentioned, we saw really good time in therapeutic range. And as Lisa will talk about, this was the important clinical factor, because we know from other studies, the higher that percentage of time in therapeutic range, the better the clinical outcomes. And so our goal was to get us up as high as we could. So Lisa, I'll turn that back to you. Oh no, I think it's still me, patient feedback. So I think the next slide is just some of the quotes that we saw from patients specifically. So Lisa, if you want to move a slide ahead. Yeah, so this is just, again, just satisfaction with care. I'll point that out there. So 96% of patients in the CPAMS project rated the care a 9 or a 10, compared to only 58% of patients in usual care. So, a significant improvement for patients. So I'm going to turn it back to Lisa, who's going to talk a little bit about provider success.
Yeah, so pharmacists in my slides seem to be slow to move here. Pharmacists in the study also reported great satisfaction. Here we go. So, and mostly in the area of improved confidence and knowledge and skills, improved relationships with the other providers that they were working with, loved that interaction with physicians and nurse practitioners, and then improved job satisfaction because of the improved relationships they had with their patients, and really that being able to be more directly involved with medication management and making changes that had a real positive impact for the patients. That was very rewarding. What we heard from the primary care providers as well was that they felt the benefit and value for their patients was there. They indicated that they only heard positive feedback from their participating patients, and that probably speaks to that convenience factor, as well as that relationship they were having with their pharmacists. Some primary care providers indicated they enjoyed collaborating with the other healthcare providers as well, and they appreciated the opportunity to work with the local pharmacists. And I personally have heard a number of times that it was sort of opening eyes to, what else they might be able to do together. So increased collaboration just in general. And most primary care providers also did report a savings in time. And then, so these are direct quotes. So one said, "I'm extremely satisfied overall from my perspective working as a primary care provider. Anytime we can find ways to delegate the multitude of patient care tasks we have, we need to juggle and manage, that can be delegated to someone with expertise to manage, then we can focus on other things." So just in the interest of time, I'll keep moving. But there were some other quotes there. So then, as far as successes for the healthcare system, so this is based on successes that were reported from providers and patients that they perceived would be a benefit to the healthcare system, but that improved collaboration again, improved safety for patients taking warfarin, increased efficiency in the system, so reducing ER visits, and also a significant reduction in laboratory blood collection clinics, so decreased burden on those very, very busy blood collection units. And we're seeing that a lot now with COVID-19. We're getting requests from around the province for additional services in this area because some of the blood collection clinics are overwhelmed today. We'll send this one over to Allison.
Yeah, so I'm going to quickly just talk about some of the key learnings, because I think we've gone through a lot of these, and I'd like to get to the costing analysis. So, I mean, what we heard and from all the providers and patients in this is that they would like to see the program expanded. Patients and pharmacists in particular, and I can speak to the physicians now. Our physicians are advocating alongside us to have this project expanded. Pharmacists would like to manage a broader range of INR. And so that was a result of, that was a learning from the project. What I can tell you is that's happened. Our scope of practice in Nova Scotia, as Lisa alluded to earlier, is broader than it was when we commenced the project. So pharmacists can now independently manage INR and adapt the prescription for a full range of INR results until such time as they need a new renewal of the prescription. One of the other key learnings here, and we see this repeated in our projects, and I'm sure everybody would concur, the IT, or the lack thereof, and the lack of interconnectivity between providers was a drawback to this project. So our tests, we did send the test results to the physician or nurse practitioner every time, but they didn't go into the same spot in the EMR where other test results. So if they'd had a blood test done at a lab, these results were in different places. So again, the lack of interconnectivity between providers, the lack of a common record, we see that in every single project we do as an issue that needs to be addressed. So I'm going to, I think, just skip through the other ones in the interest of time, because I really want to get to the costing, because that is an important piece for our next steps. So Lisa, I'll turn it back to you.
Sure. So I think you were going to speak to the costing study.
I'm sorry about that, Lisa. I didn't realize this was my slide, but I'm happy to do it. So the original costing study, as I mentioned to you earlier, was to evaluate CPAMS as compared to usual care. So we found out through the clinical evaluation that it was a better outcomes and whatnot, but could we get those better outcomes at what cost? And what we knew of what is somewhat unique in Nova Scotia is that physicians are paid anticoagulation monitoring fee when they monitor patients through the usual care. During the project, we didn't make any adjustments to their funding model, and we just included those costs in our analysis, knowing that in a permanent state, both providers aren't going to be paid to do the same thing, but we didn't want that to be a factor in the study. So what we found from the costing analysis is that the CPAM service would be a cost savings to government if that anticoagulation fee was no longer paid. So not only would we get better results in all cases, except where they continue to receive the same fee they did today, it would also be a cost saving. So again, a win-win for the government, win for patients, and a win for pharmacy. So again, as we mentioned earlier, that was great, but the world had changed a little bit since we designed the evaluation, and now the NOACS were going generic, and was a lot, or is and continues to be a lot of pressure on policy makers to make the NOACS a first-line therapy instead of being on warfarin. In fact, some of the letters that were quoted to me were like, "Don't force me to take rat poison," as that's the other use of warfarin. And so people had this really negative image of warfarin. So we weren't just comparing to usual care. We now knew we needed to go back and say, okay, how does this care compare to NOACS? So now I'm going to turn it over to Lisa, and she's going to talk a little bit about that.
Okay, so in addition to patients and government asking what about NOACS, pharmacists, physicians, all sort of asking these questions, where does that all fit in? And one of the things that we did discover in the project is that pharmacists do have a unique position to be able to identify those candidates that should be switched to NOACS. So they're doing those regular assessments. Every time they do an INR, there's an assessment process that goes along with it. So for those patients that are not able to attain that sort of benchmark TTR of 65%, we did see in the project that some were switched to NOACS, although not all. And it was identified that pharmacists sort of were in that unique position to know why aren't they attaining that TTR? What are the other factors involved? Are there adherence issues? What things could be addressed? And then at times they felt that the patient just was not a good candidate for warfarin and that a NOAC would in fact be better for them to attain their goals. So they were switched. So we wanted to sort of look at where does that fit in? We know that the randomized control trials that compare NOACs to warfarin have an average TTR of 64%. So that's where that sort of benchmark of 65% comes in. So the trials range from 55 to 68%, depending on the NOAC that was compared to warfarin. And what these RCTs found was that warfarin was found to be non-inferior to NOAC. But what we wonder and what we don't have a trial for is what happens when the TTR is 75% or 85%. Does warfarin then become superior? And so we looked to this it's an older paper from 2007. But the comparison of outcomes among patients randomized to warfarin therapy according to the SPORTIF-3 and SPORTIF-5 trials. So really taking a look at sort of different categories of TTR and how that impacts outcomes. So as far as bleeding and clotting goes. So there was the category of patients that had a TTR of less than 60% compared to those that were in the 60 to 75% range, and then those that were 75% or greater. And the outcomes that were apparent from this paper is that in addition to, so mortality itself goes from 4.2% down to 1.68% when they go from less than 60 up to 75%. And if you want to take a further look into this paper, it also goes through each of the individual adverse events. But again, you see a significant decrease in hemorrhages, in stroke, in patients that have this significant improvement in TTR. So with our addendum to our costing study, we knew that in CPAMS, we took the patients that were in our original study. 2/3 of them had a TTR of 65% or greater. The other third, we said, okay, now if that other third, less than 65, were switched to NOAC, the remaining 2/3 in the study would have had a TTR of 85.7%. And this was the number that our economist used when she was doing the costing addendum. And what she found was that this sort of optimized version of CPAMS, where you have some that are trialed on warfarin for a period of 3 months, and then if not able to attain that TTR of 65%, they're switched to a NOAC, that this would continue to be effective and more cost effective for patients than simply just going straight to a NOAC right from the beginning. And that was even when she compared it to generic pricing for the NOACs. So we know that still CPAMS is cost effective. So in summary, so if I'll just summarize some of the key things that we've talked about. So TTR is 75% for all patients in the last 5 months of the CPAMS study, and those patients that continue on in the project today, compared to 50 to 60% for usual care. The top 2/3 had a TTR of those that had a TTR of 85.7%. Patients preferred the program to usual care. The clinicians found it professionally rewarding. It was accepted by participating family physicians and nurse practitioners, and there is a cost savings to government through the reduced clotting and hemorrhagic events and also treatment savings. Alison, over to you just to talk briefly about the next steps, and then we'll take some questions.
Sure. So just very quickly, as Lisa's mentioned, this was a demonstration project. And although all of the patients that were in the demonstration project continue to be serviced by pharmacists pursuant to this project, government needs to make a decision about the future of CPAMS in Nova Scotia. So the purpose of the costing addendum that Lisa just referred to was to address the policy concerns around NOACs. So we have provided government with all of the sort of study information and analysis that we can. And we are hoping that they will roll out this project into a permanent form, as New Zealand did as well, in the near future. As with everything at this time, COVID has thrown a wrench into planning for anything other than COVID. So I'm not sure what the timeline for that will be, but we're hopeful. And we think COVID is actually impacting this and may actually help to make a decision sooner, because as Lisa mentioned, blood labs that have gone to appointment-based systems are very backlogged, which isn't conducive to warfarin monitoring when you have to wait 2 or 3 weeks to get into a blood lab. So there is some COVID urgency created around this project, but we will be continuing to work with government, and hopefully we'll see some change in 2021. So with that, I'll turn it back over to Jason for questions.
Yeah, thanks very much. And before we go on, just a reminder to all participants, you will be getting a copy of the slide deck, and we'll find a way to get you the video. But in the Netflix generation, how this works is you give people a teaser and then you have to come back for the full one. So look, the results just seem outstanding and from all stakeholders' point of view. So my first question is, to what extent could this be implemented in other places, which you just hinted at? And also, as a follow-up, how can the pandemic maybe be seen as an accelerator of this project, given that we want to kind of alleviate some of the burden on other centers?
Yeah, so I'll take that. So this project can be reproduced in any pharmacy or any province or any other country for that matter, where pharmacy has the scope like we do in Nova Scotia. So part of what the enabling factors here is we can do point of care testing, we can do prescription adaptations, we can do prescription renewals. So there is a fair amount in our scope of practice that may or may not replicate in every other province in the country. So certainly in those provinces where it could be reproduced very easily. Like you say, we didn't recreate the wheel here. New Zealand had done this very successfully, continues to do it very successfully as a fully funded federal program there. And we could easily do that in this country as well. And again, your comment around is COVID changed this? And I think in some ways it has. We certainly at this office are receiving more calls in the last month about, can you expand to here? We're getting a call from communities where they don't have access to labs, or their labs are overrun, or their doctor has gone, is just doing virtual care and they want to see somebody in person. We're getting more calls than we ever had to expand that. And that's all driven by the realities that COVID has created.
I mean, among other applications that are quite evident, the unattached patients you talked about, what a group to be able to service in a way that if they're not getting their tests or that kind of thing, then that's a real problem. I'm going to turn over to Francois in 2 minutes. So my last question may not be able to be answered in 2 minutes, but in terms of implementing this in other places, what would you say are some key steps, or even if that's too large, some key first steps in order to expand?
Well, I think the first step is, working with pharmacists and as there's an association in all the provinces working to identify this as a role that pharmacy wants to take on. So we know that other provinces are looking at this already. So I'm not going to I'm not letting the cat out of the bag to say, British Columbia is looking at this project. Other provinces are looking at this project to see how they could implement it there. And they've been waiting for these results. I think the other really exciting thing that I'll end on is we did this for INR management, but think about any chronic disease management that requires sort of frequent contact and testing to help people keep on track with lifestyle choices that impact their care. So we are already looking at, how do we take this type of convenience and access model and apply it to hypertension? How do we apply it to diabetes management? These are two areas in particular where there is already great research out there that demonstrates pharmacists are capable and competent and very effective. And we know if we combine that with the convenience factor and sort of the point of care testing, that we have the ability to take this model that we've looked at today and expand that into other areas to help patients manage their chronic disease.
It seems without question there is so much potential for this specific project and other similar ones to expand. Just before I turn it over, in addition to thanking both of you, which Francois will do also, just a reminder about the Healthcare Management Forum, that whether as an author, a peer reviewer, or a reader, this presentation, I think, demonstrates what a valuable resource that can be on all three fronts. So thank you on our behalves, but to close things off, my colleague Francois.
Thank you, Jason, Allison, Lisa. Thank you. First, when reminding me in your opening remarks that New Zealand was a first adopter of the model, you also reminded me how sometimes it's great to steal shamelessly, something that I will quickly bring back into my arsenal. Thank you for sharing the outcome of your pilot study and for achieving these great results for the benefits of patients. This is definitely a compelling story that I hope will resonate with your decision makers in Nova Scotia, but also in other jurisdictions across the country. And thank you for your leadership in this space. For those familiar with it, what I take away from the results is how this is truly the quadruple aim in action, frankly. So with that, ladies, I would like to thank you once again for the great time we spent with you today. And for those attending, thanks for making the choice to spend the lunch hour with us. And I wish you a great rest of the day. Thank you so much.
Thanks, everyone.